Radiography examination content specifications. I know that's kind of a long phrase, but if you start typing in ART, it's going to fill it in for you. So this is how you find everything that will be on your exam when you graduate. All right, so it's ARRT.org, American Registry of Radiologic Technologists. On here, you guys are going to use radiography. So remember, there was kind of a discrepancy between the competencies that you needed before you graduated, if we were using the new one versus the old one. This is one of the reasons why we're using the new one, because your exam changes in January. So the old competencies are paired with the old exam. The new competencies are paired with the new exam, which you guys are going to be taking. So every few years, they update these exams, right, to keep them pertinent to the field. It's practicing medicine, technology's changing, so that's why they update them. So we have to learn the new information too, because this is different from when I tested the registry. I've had to learn a couple of different things here and there, and obviously they took film out from when I was in school. So they change it, update it, develop it. So this is why it's really important though. If you click on the other one, that is not going to be your exam. There's only a few changes, but stick to the 2022, okay? January 2022, which is what you want. All right, so the first page here, it tells you the breakdown. It gives you a little bit of information, tells you what they're actually testing you on, knowledge and cognitive skills. They're not going to test you on anything physical, meaning you're not gonna have to perform a chest x-ray or an upper GI or a BE or anything like that, right? No practical aspect to it. It's just on the computer, straight questions. No extended response, and you get a preliminary score as soon as you submit your exam. So you'll select your answer, go to the next one, select your answer, go to the next one. If you're not sure of your answer, you are able to skip. If you skip it, it will automatically flag it for you. So you'll have a category at the end where you're able to view all of the flagged questions or all questions total. So you have the option to go back to every single question still. Do I recommend going back through every single question? No, because you will change your answers, right? So use the flag button when in doubt. The exam questions should not be tricky like they are maybe here in the program. I don't know, I haven't given you guys an exam yet. But some of these questions in the program could be tricky. What's the more correct answer kind of thing? The registry is not going to do that to you. They want to know that you know what you're doing and how to expose a patient safely, how to take an x-ray, how to position them, and that you know your anatomy. So it's basically going to be straight to the point. So right here it tells you your content breakdown. So you're going to have 33 questions on patient care, 50 on safety, 51 on image production, 66 on procedures. So procedures is the heaviest weighted portion of your exam. There's a ton of questions on these. And this is the most missed category on the registry because it is so much information. So when you scroll down here, well actually let's pause right here. So it says 200 questions total, right, that are scored. And then it says under here, each exam includes an additional 30 unscored pilot questions, okay? So what the heck does that mean? You're gonna have 30 questions mixed in your exam. You're not gonna know if they're scored or not. It's not gonna say you for unscored or anything like that. It's just gonna be random within your exam. Everyone's exam will be pooled, so it's gonna be different from person to person. You might feel like you had more questions on this. You might feel like you had 5 questions on upper GI, blah, 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 blah. It's gonna be split up. But your pilot questions, you're not going to know if they're unscored or not. So it's not gonna say a pilot, it's just going to have a number beside it. You'll have 230 running questions for your exam. All right. What they do with these pilot questions is they kind of gauge, are 90% of programs answering this correctly? Okay, we could probably safely put this on the registry and add it to the content specifications. Are only 2% of people answering this correct? Maybe we need to drill it in a little more. So it's just kind of a gauge to see where the educational standards are here. And then they do it regionally, ethnic-wise, and by sex as well. So just the retention of information. Under each subcategory, they give you a breakdown. Patient care is just one because it's a very, very small section on the registry. But under safety, we have radiation physics and rad bio, and then radiation protection. So 21 and 29 questions. Under image production, you have image acquisition and evaluation, which is basically physics, right? The physics, and then equipment operation and quality assurance. We cover a little bit of QA in this class and rad bio in the rad bio class. The pathology class will cover some of the image evaluation and acquisition as well. Procedures, you have 18 questions from head, spine, and pelvis, 20 from thorax and abdomen, and 28 from extremities. Okay, so they're breaking them down for you, right? Okay, but then when you scroll down, it's gonna break it down in detail for you. Okay, so this is your patient care section. So you start with ethical and legal aspects. Number 1, patient's rights. What are the patient's rights? The consents involved, informed, oral, implied, written consent. And then it goes to HIPAA and confidentiality, the AHA, the patient care partnership, which is the Bill of Rights, privacy, who can you share the information with, extent of care, do not resuscitate, also, what's the other one in there? Extent of care. Oh, do not intubate. Access to information, who can have it, when are they allowed to have it, is there a written form involved in it, living will, I mean, it goes into detail, right? For every single one of these categories. So the first 2 pages are just on patient care, and then it starts the safety section. Again, breaks it up into rad bio versus radiation physics. Flip the page here, now we're in radiation protection. Image production, they give you a nice little chart that talks about how the factors play a role in receptor exposure, spatial resolution, or distortion. Gives you a nice little technique chart there. And then we come down to the end of this to procedures. So this is really where the in-depth portion of the exam comes in. It tells you the following section addresses imaging procedures for the anatomic regions listed below. Questions will cover positioning, examples, topographic landmarks, body positions, paths of central ray, positioning aids, and respiration instructions. 2, anatomy, including physiology, basic pathology, which we're going to know, and related med term. And then 3, procedural adaptation, whether it's a body habitus, a BMI situation, if you have a really large patient, hyposthenic body type versus an asthenic, trauma patients, pathology, age, limited mobility. 4 is going to be evaluation of displayed anatomical structures. So this is basically your image analysis section. So patient positioning, what can we do to improve the technique? What can we do to change the rotation? Is it over-rotated? Is it under-rotated? These kind of questions. This one's kind of hard. 2-part image receptor alignment. So in detail here, it tells you, again, subcategories again, head, spine, and pelvis. Head, spine, and pelvis. But then, when you go down here, it tells you every projection and position that you need to know. Okay? So this section right here, this first one, sorry, this first section right here is only on head. So they want you to know from the skull, the apiaxial, which is the Townes, the lateral, the PA axial, which is the Caldwell, the PA, the SMB, full basal, cross table beam if it's a trauma patient, trauma AP axial, reverse Caldwell, trauma AP axial Towne. So you can see the positioning portion of this exam is huge, right? So if you don't have a good basis on positioning, I would highly recommend kind of taking a little bit of time from each week or each month and working on that information. When we are in the last class, what I do when I teach the RAD seminar class is I go through this line by line by line. So you're gonna make a study guide to this. I want you to make a study guide for it because I want you to find your gaps personally. So you could remember something that she forgot from patient care, or you could be good at spine positioning where she could be weak in it. So you want to find individually what you're struggling with. That's why we do the line by line by line. But the positioning portion is huge, so if you want to start on it now, feel free to. Okay? We're going to cover all of this in the last class, but you are going to have a lot of homework. I'm not going to be doing the study guide for you. You are going to do it before you come into class. When I give you a section, for example, let's go up to the top. All right, if I say this week, I want you to do patient care, section A, B, and C. You're gonna come in either with it on your computer, with it on flashcards, or on paper. You're gonna have the information written out or typed out, however you prefer. I don't care. I'm gonna look at everybody's to make sure and confirm that you did it, and then once we're all on the same page, we're gonna review it. So we're gonna go through line by line. What are the patient's rights? What do you guys have for this? What do you guys wanna review? What do we need to talk about? What are we missing? And this is to ensure that you know and have discussed all of the information. So learning and retention of information is really based on repetitiveness. So hopefully you've already heard this information once. Who taught your positioning classes? I probably don't know them, right? Melanie Hughes. Oh, is she a Kaiser student?
Yeah.
She's a Kaiser student, yeah, I think I did teach her.
She worked at South and then here and at Wolfson.
Okay, okay. Did you grasp some information from positioning classes, hopefully?
She was good with this. Yeah, she was good.
Okay, good.
She wasn't here super long, so.
Okay, all right, and she didn't teach you guys skull,
No.
right?
No.
But everything else?
Yes.
All right, so we'll review skull in this class. We'll go up to the lab and I'll show everybody the demonstrations of the projections while we're in here. I want you guys to actually have everything before we go into that last class. But the positioning portion is huge, so if you want to start on this, feel free to. You probably don't want to start with skull if you feel least comfortable with that, right? So I would start with something you are comfortable with. So if you want to start with thorax and abdomen procedures, scroll down here. And it starts out, it says under thorax, chest, PA or AP upright. So what do you need to know about it? Positioning, any landmarks that you use, body position, central ray, and respiration instructions. You also need to know any anatomy associated with it. Hopefully you know that. Don't kill your hand. Kind of abbreviate if you need to. Don't jot things down if you know them like the back of your hand. If you don't know it, write it down or type it. It will help you memorize it, I promise. Evaluation of the structures. So what is the patient position? What is the two-part image receptor alignment? Meaning, do we use a 14:17 portrait or landscape? Do we do it bucky? Do it standing, erect? So everything that is covered on those first 4 points for procedures is on this sheet, okay? So it's all on here for you. It says anatomical part, projection, IR. The second category is part position and patient position. The third one, central ray with ambulation, SID, respiration instructions. The fourth one is structures best visualized, and the fourth one is exposure factors and pathology demonstrated. So this is kind of your cheat sheet, right? If you want to turn these in for your actual positioning section when we get to the last course, you're welcome to do that. It doesn't have to be organized like this as long as you have the same information needed on this. I don't care how you organize it, type it, write it, flashcards. I recommend flashcards. They're very useful for studying and retention of information. It's proven, just don't bog a flashcard down. So you don't want like a paragraph of information on the back of your flashcard. You want like bullet points, small to the point information. All right, questions on that?
Questions for next semester?
Yeah. So we'll be starting in January, and this is your study guide for the ART registry. So I highly recommend looking at this. It's gonna seem overwhelming at first, but we will get through everything. And it gives you kind of an appendix here for attachment A and B. Attachment B is just your positioning terminology. It goes through supine, prone, decubitus, recumbent. You probably already know most of this information. They can also give you pictures on the registry. So you might have a diagram like this, you might have an x-ray. Really, all questions are fair game except for true or false. There's no true or false on your registry, and there's no extended response because you know you get your score immediately, so nobody's reading through them at the moment. When you get your preliminary score, you guys know what score you have to make to pass, right? Does anybody know? 75, right? 75, somebody said it. So you need a 75. So if it says anything over a 75, it's gonna have a green pass underneath it. If it's under that score, it's going to say fail or retest. Hopefully you don't get that, right? We all want to make sure we pass. But here's my recommendation as far as testing. I know I haven't taught you guys from the beginning, so I don't know kind of your gauge of information. I'm going to try my best to plug in the gaps. but I can't back up a full year in the program. But we are gonna do the review class together, so we should be able to find your gaps of information or information that was missed or whatever. I know you guys were online for a large portion too, so we wanna make sure you get as much face-to-face time as possible. But my take on it is, obviously you wanna pass the first time, so take as many mocks as you can. There's a lot of resources available for you guys. Rad Tech Boot Camp, if you've heard of that, that's a really good resource. Is anybody a member of the ASRT?
Yeah.
Okay, good. If you're a member of the ASRT, you know that they have learning resources like mock registries. I would take as many mocks as you can. The more times you look at the questions and repeat them and look at the answer, why you got it right, why you got it wrong, you'll find what you're missing information on. If you take a mock encompassing all 5 of the categories, it will tell you your weak areas. So it will say you missed 40% of the procedure questions, or you missed 30% of image production. So you'll be able to find your weak area based on an assessment from a mock registry. In the last class, I don't give you any other exam besides a mock, so you'll be taking 4 mock registries your last semester. The first one is usually the hardest to prepare you, and then we kind of back off a little bit and make the questions a little easier for the second one. The fourth one, I've had like almost everybody make almost the same score on their actual registry of my students. So it's a pretty good gauge of what you're gonna make. Don't test until you're ready. Obviously, my hope is that you'll be prepared and ready at the end of the program to test the next day or the same day, but you know what you know. I can't evaluate you each on a personal level, so if you feel like you're not ready, you're probably not. Study more, okay? If you need to take time off of work, do that. If you need to put things aside, go somewhere, get out of your house, get away from your kids, you need to do that to prioritize, to study. Because you're not gonna pass this test without putting in the work. Nobody else is gonna be taking it for you. So how does it go as far as testing? I don't know if you guys, do you guys already know all this information? Okay, I just didn't wanna be like redundant telling you the same information if he already did. How does it go testing wise? You're gonna go to a Pearson VUE Testing Center and you will have an appointment already set up. So you will set that yourself, but I will sign off for you to take the registry online. So I'm gonna say, you have completed the requirements of the AS degree here at FSCJ, and I will give my signature that you are good to test. When you set up your date, make sure you keep in mind how much information you actually know. If you know that you have to go back and study skull and spine before you take your registry, give yourself enough time to do that. Plan your study sessions, right? Plan your dates out. Much better to chunk information than cram. So instead of the night before your registry or the whole week before your registry, studying for like 6 hours a day, not proven effective, you're not gonna remember the information. So chunk it. So for, I don't know, Monday, Wednesday, and Friday, spend an hour on positioning. Tuesday and Thursday and Saturday, spend an hour on image production. But you're gonna know what you're weak in based on your mock registries. So you'll kind of know what you need to study for, specifically within the areas of positioning or image production. It's gonna be very pinpointed, I promise. Once you set up your test date, if you are not successful the first time, reach out to me so that we can talk about it. You're still gonna get a score report in the mail or email. I don't know if they do it in the mail still. They might still do snail mail, but if they don't, you'll get it in an email pretty soon. I've only had one student ever whose score has changed between the preliminary on the screen and what they actually got. It was off by a point. I'm not sure what happened, but everybody else has been very consistent. Your employer will not have access to your exam grade. They may want you to scan it in initially because you're a brand new tech and you might not have a license yet. So they'll kind of preliminarily hire you with that. But as far as your score goes, a 75 is as good as a 99. Nobody's ever gonna know, right? A pass is a pass. So you at least have to make the 75. If you're unsuccessful, you're gonna reach out to me. We're gonna discuss your weak areas and I'm going to give you a study guide and some homework, right? Because if you don't pass the first time, I want you to pass the second time. So we're gonna regroup, talk about how we can study differently, organize your schedule, create a schedule for you, and really help you pinpoint what you need before you can pass. It's gonna give you a printout of those categories and give you a score for each one. So we're gonna be able to see your weak area from the actual registry. Same thing for a mock. If you're unsuccessful the second time, you are able to retest again, but you have to do some kind of remediation for education. So the second time you test, there's no kind of time period between the first one. You could schedule the first one on Monday, get your score in the mail, and take your second one on the next Monday. But for your third one, you do have to do remediation. So somebody from the education field has to sign off on you to do this. Hopefully we will not be in this position, right? We're gonna learn a lot of information really, really fast and retain it all, because you're all gonna get plenty of sleep, drink your water, exercise, come in with a brain that's alive, right? Be ready to learn, hopefully put in the work at home. All right, so your third time around, depending on what your score is, I would either recommend you either redoing your test specifications if you're kind of all over the place, or I would give you specific targeted areas again and make you come into class. So you wouldn't be paying for the class, but for example, if you just say, I don't know what's going on, I feel like I'm never gonna retain Physics 1, I might want you to pop in a couple days in Physics 1 next fall, right, to help you. So it depends. You don't have to get me to sign off on it, but you have to get somebody to sign off on it. So if you want my help, I'm willing to help you, but I want you to put in the work too. Let's see, what else about the test? Any questions that you guys can think about for testing?
How long do you have to take the test?
A minute per question, so 3.5 hours. It was 3.5 hours when we had 220 questions. They just added those 10 additional pilots, so 3 hours and 40 minutes. Yep, you want to come in with something good on your stomach. Obviously, you don't want to be hungry while you're testing. You're allowed to have bottled water. They don't give you scratch paper, but they give you a dry erase board. Since you're testing on the computer, you can write down whatever you'd like on there. A lot of people like to write down the number of questions that they flagged. So if you're for sure on all of your other answers and you have 30 questions flagged, you could probably submit without even reviewing and you would still pass. Kind of weighing out what you need to pass, at least. But just know that those 30 pilot unscored questions are kind of popped in around the test and you're not going to know which questions they are. So only 200 of the questions are actually scored. So if you get the pilot question right, it doesn't count. If you get it wrong, it doesn't count.
So are we gonna be issued with a calculator?
Oh, good question. So calculator on the computer, so they'll just pull it up for you. So that little small one on the computer is all that you get. So dry erase board, you can write on it. They don't like you to erase, they don't give you an eraser. So raise your hand if you fill it up. They'll come over, either designate you another one, or they will erase it for you, whichever one you want to do. Very strict process. You'll have a camera on your computer in front of you. You'll kind of be in a room like this, maybe like a square, and the computers will be all along the walls. You'll have a proctor in the middle. Never get up while you're testing. Always raise your hand. You're welcome to kind of move your arms around, look at your leg if you need to. Just remember, everybody in the room is going to be testing for different things. So you might be in there with an occupational therapist assistant, a physical therapy assistant, some kind of med-surg tech, so all kinds of people testing. So you may or may not have another, why? Why only when I have you guys? Do they work on the ceiling or roof or whatever? So you might have a bunch of different people in there. Nobody's gonna look at you like you're crazy because there's gonna be a lot of people doing that depending on what they're testing for, right? If you need to use your body, use it, that's your greatest resource. They can't take this away from you, right? Calculator on the computer, a minute per question. You'll get your preliminary score immediately. You'll get a printout either mailed to you or emailed to you. Let's talk temporary license. So when you graduate from the program, I will sign off for you to obtain a temporary license so that you can work until you take your exam. So if you're not testing for a month, I can still sign off on you in contingency that you pass. If you end up getting hired with a temporary license and then you fail your registry, it's kind of up to your employer at that point. They may say, okay, well, we will do a contingency, you have 90 days or you have 6 months to pass your registry. I don't really know how the job market is right now in the pandemic. I know that everybody wanted everybody. I got like a call from Baptist like every week for like the past 6 months, just in desperation, so I'm sure they're still really needing people. If they are in kind of that crunch tight environment, they'll probably just hire you with the temporary license and say test within 6 months. Do not wait 6 months to take your registry. You will not pass, okay? I'm telling you. You're studying as much as you're ever gonna study right now in the program while you're in school mode. So study while you're in, don't wait 6 months. You shouldn't need 6 months to study, okay? I would say maximum 3 weeks after the program. Yeah.
Where did you say those testing locations were?
There's RadTech Boot Camp.
No,
Oh,
where you'll
testing
actually
centers.
physically take the test.
Okay, so they're located all over the country. You don't necessarily have to test in Jacksonville. I know there's one off of Bay Meadows, that's the one I tested on in, and then I know that there's one in Tallahassee because I took my MAMO boards there. But they're everywhere. So I have students sometimes that say, yeah, I really wanna go ahead and test next week, so I'm gonna drive to Georgia or whatever to test, just to get it over with. Sometimes Jacksonville is backed up, especially because we have us graduating in May, we have St. John's River College, and we have a Kaiser class graduating. So it's a lot of people kind of looking for testing centers.
You said the name of it was Pearson's Testing Center?
Pearson View, yep, so VUE, Pearson View. Yep, Pearson View Testing Centers. You'll need to bring like 2 forms of ID. Don't try to get anybody to take your test for you. You'll get caught. They'll call it an ethical dilemma. You won't ever be able to test. They will pat you down before you go in. Don't try to cheat. You will get caught. You will have to lock everything, like your keys, your phone, your wallet, everything that you have on you in a locker before you even enter the room. If you have to go to the restroom, they will escort you there. Just don't try to cheat, okay? It's not worth it. You know the information, or you shouldn't be testing, right? Right? And you can always reschedule. So if your test is scheduled for tomorrow, you have until today the same time to reschedule your exam, okay? Every time you take a registry, it is $200. So you only wanna take it one time, right? $200. And then, once you guys pass your registry, you paid your $200 to ART, they send you your certification in the mail, you're on the registry page. Do you guys kind of know how to verify credentials on here? Let's see. Alright, so if you wanna see if somebody's legit, you can go to the website. This is the home page. This is kind of what it will look like. And then you click on verified credentials. I don't know if they have my apostrophe in here or not. I promise I'm legit if it doesn't come up. I'll take the apostrophe out. Okay, so here I am. It tells you where I live. I live in Jacksonville. You can choose to put your address on here, but just know that it can be public. So I usually do let my employer, so it's sent directly to them. And what I'm credentialed in. So I'm an RTRM, and it's valid through the 21st, 2021. Oh, I gotta do some CEs. All right, so my CE biennium's coming up. So I have until November, oh no, my CE's good. My CE's good. No, it's not, it's lapsing. So I have until November 30th to complete 24 continuing education credits. I have to submit this to the ART, and then they renew my license. It used to be that you could use education for your CEs, like if you're in a bachelor's program specific to radiology or a master's. It's not like that anymore, so you have to get specific approved CE credits. Usually you can find them all online. They're very easy to find. They're gonna all be priced differently depending on where you're at. If you choose to go to like a symposium or something live in person, face to face, it's probably gonna be a little more expensive. Sometimes your employer will cover the credits, sometimes they won't, sometimes they pay half. Sometimes there's in-service training where an applications person will come in and teach you how to use a new piece of equipment and it will count for CEs. Like if they get a new C-arm and they have a GE rep come out from applications, they show you how to work everything, how to use the machine, how to turn it off, how to send the images, and they'll sign off on you for like 10 hours or whatever. It depends. But CEs are not a big deal. You just have to make sure that you obtain them within the time period. So I need to start doing mine now. So
What
this,
do you have them sign off on? Like, do you have a sheet? Or?
yeah, there's a sheet and they have to be verified on the ASRT website. So asrt.org, you guys know what that is, right?
Mhm.
All right, hopefully most of you are members of it. If you're not, I recommend it. It's only $35 for a student. It's $200 for a tech. So it's much cheaper for you to join as a student. So go ahead and do that. But it will tell you the approved, not actual company names, but it will say like, we only accept CEs that are classified as A, B, and C. And it will tell you specifically on the course that you sign up for, this is an ASRT A, B, or C. And it will tell you how many credits it counts for. Another thing we want to talk about is something kind of new. It's called CQR. You'll see it on mine. Let's see, when can I have access to it? No, not before you guys graduate. So December 1st, 2022 is my eligibility date to start going in. I don't know if you guys have heard kind of like a rumor that you might have to retest or something after you take your registry. Not true. You're never going to have to retest unless you let this lapse. If you don't do your CEs for ART and you don't send them in, or you do them and you don't send them in, depending on the appeal process, you could lose your license and have to retest. Not a situation you want to be in. Remember, the registry changes, so if you're 10 years down the road and you forget to submit these or forget to do them, and they're not very generous with you and not willing to work with you, and you have to retest, you're gonna have to come on this website and you're gonna have to find the test specifications, because they will probably change every 3 years, and you're gonna have to learn new information, and it's gonna suck, so don't do that. Don't do that. It's really hard to retest years later. Not impossible, but not a situation you wanna be in. Just update your CEs. But the CQR compliance period, so what that is ASRT discovered that after 10 years in the field, techs are starting to lose their skills in one way or another, according to the textbooks, right? So if you ask someone, you know, working with the techs, they don't know what the CR is, right? They don't know any physics behind it anymore. Do they remember the interactions? Probably not. Could they pass a physics test? Maybe some of them, usually not, right? You dump all that information after you take your registry. So CQR is a test, but it's not a pass or fail type situation. So you take a test, it's basically like a baby registry, and whatever you score weekly in, they will assign you specific CE credits to take. So in addition to your 24 due every 2 years, within your CQR compliance period, you have to test within those 3 years. So I would recommend testing in the beginning of it, depending on how many credits you're gonna need. It'll be interesting to see if I need any. Hopefully I don't, since I teach the information, right? But if I do, I'll let you guys know, right, down the road, since I'll be taking it before you. But I do know somebody who took it for CT, and she said for like positioning and beam regulation, which is like beam restriction collimation, she got like assigned 3 credits for each of them. So it's usually not a lot, but I can't say that they're gonna make you not do 24 or 12. But it's additional CE credits in specific areas based on your testing score. And I don't know if you have to take a CQR test at a testing center or if you can do it at home. And I don't know the time limit because I've never taken one. But it's not a pass or fail type situation. It's just kind of to see where you're at to designate CE credits. Make sense? So they're making it legit for all of the additional credentialing. So I have to do one for MAMO too. They're kind of just working their way down the list. But older techs don't have to do this because they're grandfathered in, so they're lucky, right? Do you have a question, Megan?
I know, just figured it out.
Okay. Questions?
How often did you say that we had to get our CE?
2 years, so it's a
Every
biennium. Yep, a biennium. So I should have started my CEs in 2019, but surprise, I didn't. So, yep, mine are due this year. So you have 2 years. And then let's talk about the state of Florida. So the state of Florida. If you choose to stay here and work here after you get your ART certification in the mail, then you will apply for your license, your true license. I'm gonna apply for one, a temporary one for you, but it won't automatically change to a permanent one. So after you actually test, you have to apply for a permanent or a secure license, they call it. Depending on where you work state to state, you're gonna have to pay a fee for the license. I think it's like $50. Let's see if we can pull it up. I'll tell you for sure. Radiography, State of Florida, Department of Health. Let's try that. Okay, it's $50. It's $50. So you'll have to pay this every year. Your state license is only good for a year. But it's $50, you don't have to retest, and it's specific to the state. There are like 2 states that still don't require you to have an actual state license. I think it's Georgia and Alabama. So if you plan on working there, all you have to have is your ART, right? So no additional testing with this, we're just paying the state to let us practice. Isn't that nice? We've already went to school, we already know the information, you already paid $200 to take your test. On and on and on and on, right? If you choose to be a traveling tech one day, you will have to obtain many state licenses or licensures. Usually your agency will cover the cost of these. So if you do a 13-week assignment in Alaska or Texas, they'll already apply for you and pay the fee for you.
So you don't retest in those, like you don't have to retest, you just have to pay for the license.
Right, so your ART is gonna be your national certification. So legit for everywhere in America, not in the UK. If you move out of the United States, you will have to retest. They may not just kind of fit you over. I know one person moved to Canada, and I think they accepted it, but she had to take like a 25-question exam just to kind of see where she was at, I guess. But they said that our test was harder than the Canadian one. So they just made her take a 25 question. It was like a portion of the exam or something. But yes, anywhere within America, if you move, you're just gonna have to pay the state licensure fee if the state requires one. But you will never have to test again, right? As long as you keep up with your CEs. And you don't do anything that is unethical. If you violate HIPAA and you get in trouble for it, if you look up, I don't know, a Jaguars player or your neighbor or I don't know, a celebrity, and you get in trouble and they end up firing you, they will report you to the ART and you may have to appeal to keep your license. Okay? So everybody remember the Code of Ethics from Patient Care? Everybody remember them, hopefully. They're on this website as well. Make sure you're observant of them. Hopefully you are. Don't steal anything from anybody. Don't kill anybody. Don't take anybody's medical records. Don't look at anybody's medical records if it's not pertinent to you. So questions on licensures, ART, test time, test specifications, anything like that? All right. I just wanted to make sure you guys had this as a resource. ASRT has really good mock registries, so if you are interested in doing that, the only information that you are not going to be able to test for right now is the rad bio safety portion and some pathology questions, but pathology is not a different section on the registry, so you might just have to include all of the positioning and procedure section and then just kind of give yourself some grace with the pathology if you don't know them yet. But pathology itself is not a separate section on your registry, so you're not going to be excluded in that. If you want to get very pinpoint with it, you can go on RadTech Bootcamp or ASRT and select physics and procedures, and it will give you a registry only on those 2 sections. So you can choose what you want to be tested on. All right, just kind of get you in the mindset. You're almost there. Hang in there. Don't break down. Hang in there. All right. Let's talk about something that I ran into with my junior students yesterday. The flu and the COVID vaccine. So if you get one, you have to wait a certain period of time before you can get the other. Okay? So if you have received the COVID vaccine, they're recommending that you wait 30 days before you get your flu vaccine. Okay, so if you're in the middle of it, it might look funky. I talked to the coordinator yesterday, Trisha. She's gonna give you guys grace, okay, as far as that goes. If it's a situation where you just got your COVID vaccine yesterday, you obviously can't get a flu shot for a month, they're gonna be more lenient to you, okay? But then after that time period, you have to get it.
I think a lot of us are not compliant as of today with the flu shot, so what do we do on the Complia for that?
I would say don't do anything with it. Don't do anything with it, because I just talked to her yesterday.
Okay.
If you are able to get the flu shot, get it, obviously, right? If you're kind of in the middle of your COVID, or you just got your last one and you have to wait, send me an email. Okay, so I have the information, I can back you up when she calls me and says, why is this person not compliant?
But Complia doesn't show it as mandatory right now.
I know, and neither does Baptist technically through Baptist Health. So there's kind of a discrepancy right now. If you have submitted that, which I think there's only a couple people that have submitted that exemption, you get an email back from Employee Health that says we're not mandating and we're not accepting exemptions from people who are not employers. It's just that it's not organized yet. It is still mandatory, both of them still are. And somebody emailed me about a flu shot exemption. There is no exemption for the flu shot because you can get the nasal mist, so whatever that was.
That was me.
Okay. You have to get the nasal mist or you have to get the actual vaccine. However, you have grace as far as your time period goes with the interaction with the COVID vaccine. Because it's a brand new thing, right? We can't control it.
Who is Trish that you're referring to as the coordinator
Yeah, she's the coordinator.
of what?
The students at Baptist at all of the locations. Yep.
What's her last name?
I can't tell you because she doesn't want you to have your email. Yeah.
I just had never heard that name before, so that's the first time I'm hearing that name.
It used to be
As a
Susan
coordinator.
Conyers, and she retired. But these people are all over all of the students. So not
Okay.
just radiography, they're over nursing, PT, everybody.
Okay, so the specific radiographer coordinator, or like for each hospital, that's separate, so they're
Yeah.
underneath this Trish person.
Yeah, so Trish deals with medical records and compliance.
Okay.
As far as like schedules and everything else, that's gonna be kind of your clinical preceptor that you talk to, right? Makes sense? Yep,
So is it 30 days after you get your first shot or 30 days after you get your second shot?
either. So if you've had your first one, you have to wait 30 days. So you could get it potentially if you skipped your second COVID vaccine and got it later, which I don't recommend, right? You wanna be compliant with that when the time comes. Or you can choose to, depending on which shot you got, if you have to wait 14 or 21 days between your, okay, between your first and your second one, after you get your second one, it's 30 days as well. So it's kind of an issue. We didn't foresee it happening. We couldn't plan for it, right? We didn't know this was gonna happen. It might change tomorrow that they say the recommendation is you can get another vaccine within 10 days or 5 hours. But as of right now, they are recommending waiting 30 days.
So in regards to getting the kinks worked out, because like you said, this is new territory for everybody, as
Yeah.
far as a student filing the exemption
Uh-huh.
for the actual COVID vaccine.
Yeah.
What's the process for that? And when will we know when that process, those lines that are like no longer blurred? on what
Okay.
we need to follow?
Good question. I'm meeting with someone today after
Okay,
class.
cool, awesome.
Yep, so I have a 1:00 meeting today with someone, the dean from the college, and we're gonna conference in a couple people from every hospital, just to clarify some things. So hopefully, it should be updated today. I kind of think what's gonna happen, my impression of the situation is that we are gonna keep a copy of your exemption. We're gonna send a copy to them, and you're gonna upload the exemption on Complio. And as long as we both have documentation of it, the college is not gonna make you get it. because they're kind of leaving it more in our court now. But we still have to have it documented that you filled out their exemption. Not saying 100% that's gonna be it, but I kind of assume that based on her response. All right. Everybody
Thank you
good?
so much for
Mhm.
coordinating all that.
After our flu shot, and we have to get our second vaccine, is there a period we have to wait for that? I think you said
After
there's
flu
30 days.
Yeah, so they have to be 30 days
Is that
spaced
between the flu shot and the
Yes.
second vaccine?
Yeah, because they don't know how they're gonna interact.
I didn't know if it was just before the flu. It's
Yeah.
for after too.
Yes.
Okay.
Yeah, like if you've already got your flu shot and you have to get your second one.
Yeah.
Yeah, technically it should be.
I have a question. Are you able to see, what is it called? Not yeah, it is Compleo. Are you able to see Compleo?
I'm not. No, I can run a roster report to see who's in compliance, and I probably will at the end of September, just to make
Okay.
sure everybody has their updated flu shots and everybody's getting the process
Because
going.
I'm the only one, I haven't even opened it, and I'll probably email you again and let you know everything's good, or can you please, I had an issue with my, I think the HPV, whatever, that shot you have to take for 3 months.
Hepatitis B.
Yeah. It was saying something about, and I'm pretty sure it's okay now because I did an exemption, but I just uploaded the fact that.
That's fine, a declination form.
But I uploaded in my exemption form, I just uploaded that I did take the third one. It's just that Compleo, for whatever reason, I had to retake it as per my doctors, and I was like, all right, whatever. I retook it. But when I went to upload the third one, it was like, your third shot needs to be before your little test, your little needle test thing. And I was like,
Oh, your PPD.
yeah, I was like, what? So I was confused. And then it's not, I think it's the PPD. It's the test you have to take that lets you know whether or not you need to take the
Oh, a
vaccine.
titer.
Yeah, the teeter shot.
Oh, to
And I
make
was-
sure that you're actual immune to it.
So the teeter came negative.
Right, because
So
you're not
I,
immune.
so I had to take it.
You got a booster, so you're immune.
They made me do the 3 one.
Oh,
So I did all 3, and then when I went to do the third one, they were like, no, it has to be before your teeters. And I was like, but the teeter was negative, so I had to take it, so I'm confused.
Yeah, so there was some confusion there. And feel free, as far as that one goes, the Hep B is specific where you can do the declination. It's not gonna affect anything. And Hep B is one of those things that you wanna keep up with anyways after you heal.
What I did was I emailed the actual Compleo, and I was
Okay.
like, hey, what the heck? And they're like, oh, well, they didn't even know what to do either. So I was like, you know what? I'm gonna apply for exemption, and I just uploaded that I did get the third.
You have proof of all 3.
And then I did. I sent it, and in my little, because you know how you can type something, I was like, I got the third one. It won't let me upload it. Here it is.
Okay.
And it said that the school had to accept it. That's why I was confused.
We don't accept anything. Basically, they're kind of like our middleman between like local exchange, which it's supposed to make it easier, but everybody has issues with Compleo, so I don't really know that it does.
Okay.
It's supposed to make it easier though.
Okay. Thank you.
Supposed to.
Yeah, I was so frustrated. I'm like, you guys are the one who made me take it.
Yeah, I don't have health insurance, and it keeps telling me I'm not compliant because I don't have health insurance.
All right, so let's do
What I
some
did
vital
was
signs
I applied for an
review.
exemption, and I uploaded my insurance card, and I wrote it, and I was like, I have to have insurance. It's just it's not under my name.
But you have insurance.
Oh, you don't?
Sorry. Oh.
All right, for venipuncture, I passed out a venipuncture comp form for you guys. We're gonna wait on that. Don't sign it yet. Don't date it yet. Just keep it with you. I'm trying to get permission for us to have access to the lab, which is like right down it's just a couple of classrooms down. They don't have a bunch of arms, so the only thing they have as far as like safe things, they have like 2 arms from nursing for placement. So we can just draw on each other. I just have to get the waiver drawn up for you guys. Okay?
Like correctly on who's looking over.
Yeah.
Yeah.
Yeah. So we can make sure you do it. But I just have to get permission. Yeah. venipuncture that I passed out as soon as I came in. Venipuncture? You can get one after class there at the front. But don't fill it out yet, the venipuncture comp. All right, listen. So venipuncture is in your scope of practice, right? If you get a job within a field where you're gonna have to use it, such as CT or MR really are your main two, and nuke med, they're obviously gonna retrain you, so I don't expect you to be a master of venipuncture when we go in there, but I do want your hands on the supplies and for you guys to know what goes to what and how to draw, where to stick, the angle, all of that, right? Has anybody saw anybody start a line in radiography? All right, for what exam?
IVPs.
IVP.
Yeah.
Oh, they're still doing that.
Yeah.
Okay, IVPs. IVPs for you guys too?
We've seen pick lines.
Pick lines, okay. Phlebotomy, okay, so you can just be our leader here.
Same.
All right, there you go. So good, so we have a couple of phlebotomists in here. If you don't feel comfortable, you don't have to do it. I just want you guys to be able to see it, okay? I know some people are really freaked out about people who are incompetent drawing their blood. I get it. I would consider everybody, including myself in this room, to be incompetent right now, right? I don't draw people's blood every day. I haven't in a long time. So, but it is technically within our scope of practice. We want to know the information for the registry, so that's where we're gonna review it. I just have to get permission, so I'm trying to set something up with the MLT professor. When I do, I'll let you guys know what day we're going in there, and we're gonna do venipuncture, okay? So just keep that form for now. We will talk about it today probably. All right, so let's start on, let's see, 177.
What book are we in?
Patient care.
I think we have a different book.
Oh, you have a different one than me?
Yeah,
This one is already old. Why do you guys have that
What?
one?
Is that pathology?
No.
I have the 6th.
Red bio.
The 7th is out.
What's this one? She doesn't have that one.
Can't take this one.
We're not doing
What
rat
is it?
bio. We're doing this one.
the patient care book, should we get?
No, I just want to do a patient care review today, a vital signs review.
Mine was online and it expired.
Okay, I would get it
Oh.
probably for the last class. By the
Oh,
new
I was
edition,
so
though,
confused.
If you can,
Or what, is that the one you're gonna use for the last one?
yeah.
So this is what edition? We need all new books?
7. No, you don't have to buy new books for the last class.
Can I see?
If you want to, you can, but I wouldn't. Your notes are probably already in these books, right? They're not very different. I have the new updated version. I'm
What is
teaching
that?
from this one right now because this is the edition that you told the juniors to get, so. But this one's not the new one, so that one's probably the one I used. Ancient. All right, so hopefully they're about the same page. 177, does it say vital signs as indicator of homeostasis? Chapter 15?
Right here,
Ish.
172.
172?
Nice job.
All right, 172 in the old book, 177 in the new one. So they give us a term here in the beginning called homeostasis. Hopefully this is gonna be a review for you guys, right? Hopefully. But you were never taught face to face, so let's give it a go. So homeostasis, what is it? It's a relative constancy in the internal environment of the body that is naturally maintained by adaptive responses that promote healthy survival. So our bodies are constantly, or should constantly, be in a state of homeostasis. If they're not, we're sick, or something is going on. It talks about vital signs being the primary mechanisms that adapt to response inside or outside the body to maintain homeostasis. So it says collectively, the vital signs are body temperature, pulse rate, blood pressure, and respiratory rate. In addition, assessment of the patient's mental alertness, sensatorium is often reported along with the vital signs. So is the patient like altered mental status, AMS, are they with it? Do they comprehend basic information? You can usually tell if your patients are alert or not, right? Especially if they're sedated or they're in a coma, they're intubated, things like that. So let's talk about the difference between objective and subjective data. Do you guys remember this? Objective and subjective? What's the difference?
Like, what you see versus what you feel.
Good. So what you can actually test or what is written down is objective. So vital signs are considered to be objective data. This is probably not in this chapter, but I just want to do a quick review. Vital signs are considered to be objective data. So we will put a pulse ox on somebody, it will tell us 93%, that is objective. It's an object, we can grasp it. A blood pressure reading, 180/25, this person's dead, right? All right, but it's objective. Subjective data is feelings or things that you can't prove or show. So if it's subjective, it might be different from me to you or from her to her. For example, I've had chest pain for 3 days, but my EKG is normal, right? My vital signs are normal, my blood pressure is okay, but I'm having chest pain. So subjective data is just as important in our field as objective data, because if somebody says that something is hurting, there is something wrong in their body. We just have to research a little further, maybe test different things out, right? If somebody says they have chest pain and everything's coming out normal, something's going on in their body. You're not just gonna have unexplained idiopathic chest pain. Obviously, if your limb's falling off, you're probably gonna have some changes in your vital signs. So that would be then objective, right? Objective and subjective data. Mental alertness, I would say that's subjective as well. So if the person is not in the same capacity that they were the day before. A good example of this is like a stroke patient or dementia patients. We might not necessarily be able to test and write down data that's actually changing, but the lady lived with her husband and she said when he woke up this morning, he didn't know her name. Obviously something's going on. Subjective, if we can't find anything vitally that's wrong, but still very, very important and vital to figuring out and diagnosing and the prognosis of this patient. It gives you a couple terms here. Hopefully you know these. Diaphoresis, everybody know what that means? Anybody know what that means? Sweating. Good. Good. That's probably in the terminology section of procedures, not necessarily patient care. The first thing we want to talk about that we're not actually going to demonstrate, because I'm sure you guys probably get this done very often, maybe in the hospitals, maybe in businesses, maybe here on campus, I don't know, but is temperature, right? Temperature. So everybody's taking a temperature now. Kind of silly, right? You can be asymptomatic and have this virus. You can have the virus and not have a fever, but we're still taking people's temperatures. What the heck is going on? Who regulates this crap, right? All right, but your normal temperature is gonna be, there is a chart in my book on page 179. It's a green chart, it looks like this on the bottom, so you're probably close. It gives you your normal vital signs. So your normal temperature, 97.6 to 100.0 Fahrenheit. If you're within this range, your body is considered to be in homeostasis, right? So it's okay. Everything's going good. On the page parallel to that, so 178 in my book, it talks about 5 routes that you can normally take someone's temperature. So orally is where? The mouth. Axillary is? Armpit, good. Temporal? Forehead, good. Tympanic? Ear, good. And rectally? In your butt. In your booty, right? All right, so it does tell you that axillary temperatures are really inaccurate. I actually didn't know that until I was reading over this information again last year. But it says that your thermometer has to remain in place for 5 to 10 minutes for it actually to be a stable reading, axillary. So if somebody is putting a thermometer in your kid's armpit or in yours to take your temperature, probably not exactly a good reading. What is the most dependable or accurate reading? Rectally, right? The most common route used to be tympanic, so it used to be the ear. So you guys know in the doctor's office, they just put the little cover over it, stick it in your ear, and it gives you the temperature. But now I would say it's probably temporally, right? Because we're using those infrared readers.
I've had people do it on my wrist before too, which is
Yeah.
weird.
So again, these things are calibrated to read from specific parts on your body. Just like your dosimeter has a little picture, mine's not in the right place. Don't do like me then. Just like your little dosimeter has a little man on it and it tells you that it needs to be at the level of the chest, right? So it should technically be up here, but I'm not exposing today, so I'm okay. Gives you a little mark to tell you. Those thermometers are calibrated as well for specific body areas. So if you're using it on your wrist, it should be calibrated to a wrist temperature or a skin temp, which is not really legitimately a thing, right? Anyways, enough with the nonsense though. If you want to take somebody's temperature though, you could use any route technically, legally, but you don't want to be sticking a thermometer in somebody's booty for an x-ray, right? No need to. No need to. Anybody seen any x-ray techs taking temperatures? No, in the facilities? I don't think so either. I think nowadays you would really see them at the front of the center to get somebody in. Are you fever or not? Or are you febrile or not? So it tells you the significance of abnormalities for temperature. When the temperature is higher than 99.5, a fever exists. So they call this hyperthermia. The person is considered febrile, right? Hopefully your book says about the same thing. Conversely, when the patient's temperature falls below the normal range, which technically 99.5 is within the range, it's within that 0.5, so it's kind of a gray area there. This is where discrepancies of the textbook come in. So the registry would say more like an wild number. Like if a person has a 102 temperature, what are they considered? Hyperthermic or hypothermic? Obviously, we're gonna select hyper. So in these specific ranges on the chart, it tells you 97.6 to 100 is normal. And then on the page over here, it tells you if it's higher than 99.5, you have a fever. It's 0.5 off. It's changing all the time. So right now, if you have like a pediatric patient, if they have a temperature of 100.2, normally they consider it a fever. So really specific to the site, but it is gonna be a healthy range. So normal temperatures range between 97.6 and 100. It gives you a little breakdown here of what the average should be for each route. If you take an axillary temp, you're always gonna add 1 degree to it to get an accurate reading. Rectal is gonna be site-specific, completely accurate. Oral, you don't add anything to. Tympanic, you don't add anything. Temporal, you don't add. But it does give you a healthy kind of range there for each one to actually be safe and considered homeostasis. It also gives you on this chart the normal respirations for your body to be in homeostasis. So 12 to 20 breaths per minute for an adult, 20 to 30 breaths per minute for a child. So children move faster than us, they breathe faster than us, their bodies are smaller, so they're able to expand their lungs faster. Think of it like a scale option. How do you write down or record somebody's respirations? What do you do?
For a minute, you just watch them breathe.
Yeah.
You just watch them breathe, right? It's not really science, so you're just gonna watch the person breathe for a minute. You usually don't even tell them that you're doing it, because if you do, then people try to breathe differently, right? If you're like, okay, I'm watching the way you're breathing, you're like, okay. I mean, I don't know. You're trying to make sure you're okay, or maybe you're anxious. And then it has on here your pulse, which is basically your heartbeats or your heart rate. An adult, 60 to 100 beats per minute. A child, 70 to 120. We're gonna practice respirations and pulse in just a minute. And blood pressure, normal, 120 over 80. And then it breaks down systolic versus diastolic. I do have a couple of blood pressure cuffs that we're gonna pass around, but I'm gonna group you guys up in just a minute after we go over this information. All right, so let's turn the page and let's talk about respiratory rate abnormalities. So if the patient is breathing faster than 20 breaths per minute, they call it what? Tachypnea. Good. Tachypnea. On my book, it's on page 181. If they're breathing slower, or at a slower or a decreased respiratory rate, what do they call it or consider it? Brady, good, bradypnea. It also gives you a couple terms at the bottom of that paragraph. Good to know, dyspnea is common terms for difficulty breathing. Orthopnea refers to difficulty breathing unless you're sitting up or standing. So I always like to think about orthostatic hypertension for that one, because that's kind of a common term that we talk about in the patient care class. So ortho, referring to the position of the body. So if the person is laying down, they're having trouble breathing, either supine or prone, but when they're sitting up or they're standing, their body is erect, it's called orthopnea. So when they're standing or sitting, they can breathe fine, but if they're laying back, they're struggling to breathe, orthopnea. And then it goes into pulse, which it doesn't actually tell you within this actual section of description here what a pulse is. It's a measurement of your heart rate, if you don't know that. It's a measurement of your heart rate. It talks about the cardiovascular system, how it's a closed system, how the heart pumps from the left to the right, but it doesn't actually tell you what the definition of a pulse is. Where can we measure pulse at? Your wrist. Good. Specifically, where can you measure it in your wrist?
Over here. A lot of places.
Artery, right? Artery. So it's your radial artery. Your radial artery. So you know that your radius is paired with your thumb. So you're looking for the thumb. And if you put your finger, your index finger, right here, you should be able to feel your pulse. You're alive, right? We're all alive. We're all breathing today. Hopefully you have a heart. All right, number one thing to keep in mind when you're taking someone's pulse is never use your thumb. Why? Because your radial artery goes to your thumb. So you will feel your own pulse, right? So you don't want to do that. So always use the pad of either your index or your middle finger. Some people do them together. We're going to practice doing it in a minute. This can also measure if the person is having strong or irregular heartbeats. So if you're feeling a pulse, maybe it feels weak or irregular when you're doing this. A good time to take pulse is if somebody passes out and you need to perform CPR, right? Or if you find somebody who's unconscious, first thing you want to do is feel for a pulse. If they have a pulse, you start CPR. If they don't have a pulse, you get the AED, and then you start CPR, right? So we want to keep these people alive. It does tell you your common areas that you can take the pulse rate under the measurement on page 181. The most common is the thumb side of the wrist for the radial artery. The second most common is the brachial artery in infants usually. So this one's usually only specific to pediatric patients. And then you could also feel for the carotid in the neck. So it gives you a little picture here. Figure 15-4, one of the common sites for measuring pulse. So when we're practicing today, we're going to practice to find the pulse using the carotid and the radial artery, so you can feel the difference between the two. It also gives you an image of a stethoscope over a chest on figure 15-5. Hopefully this one's in your book. They call this one an apical pulse, and it's counted by listening to the oscillations. So if you ever have somebody listen to your heart, they want to place the stethoscope above the apex of your heart, not the apical of your lung. So apex of your heart here, and listen, and they're going to count. All right, let's turn here. Let's turn. What else do we want to talk about here? We want to count pulse for how long? A minute, good. So counting pulse is the same as counting respiration, so 60 seconds for each one of these. And resting pulse rates, it tells you, should be between 60 to 100 beats per minute for an adult, 70 to 120 for a child. Let's see. How about a pulse ox? I'm sure everybody has saw one of these, right? A pulse ox. It's not within the chart. It's not within the green chart for the specific normal homeostatic vital signs, but you want to know this one. It's on page 182. It tells you a normal pulse ox value for a healthy person would be between 95 to 100. Everybody see that in their text? So 95 to 100, you usually wear this just on your finger. I brought in a pulse ox that I had at home. This is kind of becoming a super common thing now. If you get COVID or if you've had it, my doctor said the first thing when I met with her virtually, she was like, go ahead and order a pulse ox so you can make sure you monitor your oxygen. If it dips below 90, you need to go to the hospital for oxygen. So more commonly used at home these days, whereas before they would just kind of use it as a vital signs for you to check in to an outpatient center. But more and more people are kind of starting to do this at home, especially with our technology. If you have a smartwatch, you can probably take your pulse, right? You can probably take it already. Some devices will take your blood pressure as well. You can get those at-home kits as well. So everything's becoming a little bit more independent these days as technology advances, and you don't have to go to the doctor for something. So pretty cool. All right, let's talk about blood pressure on the next page, 183, blood pressure. So they talk about only really the diastolic pressure, which is the relaxation, but they don't talk about the systolic. The systolic is the contraction. So the systolic is the first initial push of blood. So when it contracts, it pushes through, and then they talk about the diastolic, which is the actual heart relaxing. The two things that you need to take a blood pressure are what? Stethoscope and a blood pressure cuff. So good, those two things. It gives you a little image here. We have a couple up here that I'm going to pass around for you guys to use. Technical term for a blood pressure cuff. I love this one. I can never say it right. Sphygmomanometer. 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 So technical term for a blood pressure and a stethoscope. But the sphygmomanometer consists of a cuff, a tubing, a valve, and a bulb. So obviously, all you need to do is tighten the actual bulb. So you tighten it up with the little vial that's on there. You're gonna pump up the cuff. Usually on a healthy person, you won't need to go over like 180. If you are worried about the patient's condition, you could probably pump it up to 200 standard. When you slowly release it, you listen for the first initial pump of the heart. When you feel that or hear it in your stethoscope, that's going to be your top number. When you hear the last one, as you're slowly releasing it, you're going to hear your last number. That's going to be the bottom diastolic number. A lot of these are automatic these days, right? You guys aren't required to buy stethoscopes as rad techs, nurses, CNAs, med techs. They usually have these respiratory care therapists, people like that. They have these so they can take a manual blood pressure. It's good to have one. I like to have one at home. I have a Littmann at home just to listen to my kids. Good stuff to have so you don't have to take them to the doctor if you know how to use it. But not necessarily a requirement to know how to do a manual reading, an automatic reading. Anybody used an automatic reader clinically? Okay, good. Most people, right? So did you know how to use it?
Yes.
Okay, what's the most important thing about the cuffs position?
The artery.
The artery, good. So we want to make sure the little valve that leads to the pump is lined up with the brachial artery in the arm. And we're going to demonstrate it too. We're going to demonstrate it. So if the blood pressure is high, it's considered what? Hypertension, good. Hypertension if it's high. If it's low, it's what? Hypotension, good. Let's see if we need anything else on this page. I don't think so. Blood pressure is known as the silent killer. Lots of people have high blood pressure from salt intake, from stress, exercise, things like that. Probably about a third of you in this room have high blood pressure, I would say, based on your age. But it's a silent killer. You always want to regulate this. If you do have high blood pressure, take your medicine, exercise. I know I can tell you not to stress, and then you will still stress, so try to not stress. That would be good. But all of these play a key factor in our body in maintaining homeostasis. Stress is very damaging and debilitating to your body. Even your weight can be controlled by your stress, and your adenomas released. The next page, it talks about oxygen therapy. We're not gonna go over this one, because we don't administer oxygen. We know that there's different ways that it can be prescribed. Remember, oxygen is a drug and it has to be prescribed. I can't just walk in a room and say, you're breathing kind of slow, let me give you some oxygen. Illegal, right? It has to be prescribed from the physician. So oxygen takes a prescription. It also takes a prescription to tell us where it should be delivered or in what manner. Do they need a nasal cannula? Do they need a mask? Do they need to be put on a ventilator? So these are things that are really talked about these days since we're in a pandemic and we're dealing with a lot of respiratory issues. If you want to, you can read through the nasal cannula, the mask, the tent, and the oxyhood. If you get a chance to rotate through a PEDS rotation or Wolfson, which most of you should, do you? Have you? Some people, maybe.
Switch it up.
Okay. Okay. All right, so the oxyhoods are really common in the NICU. So if you have a premature baby, you're gonna see them. It's on page 189 in some kind of structure like this. Sometimes it goes over their full body and it's fully oxygenated just to help the lungs that are underdeveloped be able to breathe. It also shows you an aerosol mask on page 189. This is used if you're administering any kind of steroid like albuterol, or sometimes they just use saline mist to loosen things up. You won't see that being used in the hospitals to treat COVID because COVID is thriving in a wet environment. So they will use nebulizers or, they won't use nebulizers, I'm sorry. They'll use inhalers that are dry. And then it has a, what is that? That is not a nebulizer. Oh, on page 189, it shows you figure 1520. It's a nebulizer to create high humidity in the form of a mist in a room. So not a nebulizer used with a mask. It's used for a room type environment. Kind of think of it like a dehumidifier. Chest lines and tubes we're not going to go over either. So let me pick up my page and see where we're going next. All right, I do want to talk about drug administration, but first I'm going to give you guys an assignment to do. So we are going to test taking pulse and respirations. So get a pen if you don't have one because I want you to write this down. You're going to group up in groups of 4. It doesn't have to be 4 exactly if we have an extra person, which we might have 1 extra person. So one group of 3 or 5. So you start with your 4 people, and you're going to start with a resting pulse rate and a resting respiration. Okay, so I want you to record it. Resting respiration and resting pulse rate. Then, I'm sorry, I want you to take that radially and with the carotid artery. So you should have 2. So radially and with the carotid artery. So we're going to practice doing both. If you have a smartwatch on, you're welcome to compare your pulse rate to see if it's actually accurate.
Sounds good.
Right, you can do that. Next, I want you to take the stairs. Okay, take the stairs if you're able. If you're able to do all 3, that's great. If you're not, do 2 or do 1, whatever you can do. Then I want you to take a pulse and a respiration rate again. For this one, you can choose to do whichever side you want for the pulse. So if you want to do the radial versus the carotid, you can. Only 1 for this one is needed though. Then I want you to take a 2-minute delayed one. So 2 minutes after you go up and down the stairs, right? Your heart rate should be pumping. It should be much higher. We'll see how in shape you are. No, I'm just kidding. Just kidding. Different people have different pulse rates. But then a 2-minute resting one. So after you've sat down for 2 minutes, maybe you got a drink of water. Don't wait longer than 2 minutes because we want to see how fast your heart rate is actually decreasing. So again, you're going to take a pulse and a respiration. Remember, don't use your thumb to detect the pulse because it's not going to be accurate. And I am also going to pass these around. So I don't have one for every group. It was really hard to locate these. Okay, this is one itself. But I want you guys to pass it around, and at least within this time that I'm going to give you 30 minutes. So within the time between now and 10:30, I want you to at least take 1 blood pressure. okay? So everyone in the room, I want you to take at least one blood pressure. So if I start you with this, you wanna go ahead and start to try to me, okay? Stop me. And again, I don't want it to be repetitive, redundant. So if you know all of this, we'll go through it very quickly. So we're gonna start on page 285. And this is the chapter on the principles of drug administration. So 285. So the first thing we want to know when we're administering drugs are the 5 rights. The 5 rights. So it has them listed: the right drug, the right amount, the right patient, the right time, and the right route. 285.
277 in the,
277, depending on which book you have. 285 in this one. Everybody tracking?
yeah.
All right, so the 5 rights of of drugs, the 5 rights. So it goes into detail. The right drug, you're supposed to check the name 3 times. It gives you 3 scenarios where you could, once the container is removed from the shelf, again when the drug is removed from the container, and then a 3rd time when the container is replaced. The right amount. Oh, important to know for right drug. If you ever draw up something for a physician, an RA, a PA, you always want to leave the original container out so that they can see and verify that they are also administering the right drug. So where does this come into play with us? Contrast media, if you're doing myelograms, arthrograms, things like that. You're gonna want to actually leave the vial of the contrast out on the tray so that they're able to verify that they're giving the correct drug and that it's not expired. They're gonna double check it again before they administer it. So never throw that container away until the procedure is done.
Just watch that happen with the PA, like, gave the patient double, lidocaine instead of contrast media.
Oh,
It's a hot
shame
mess.
on him.
Yeah.
All right, always double check. That could have been bad. The right amount. So we obviously want to give the dose that's prescribed or recommended for contrast media. We don't have a prescription for contrast media, so we don't have to be prescribed it or a written order for it. However, you know, whoever you're working with, radiologist, PA, they have specific things that they want. Maybe for patients who are over 20, for upper GIs, they do fizzies, thin, thick. Maybe they only like one. Post films, they usually have a preference. Maybe they like all of them prone. Maybe they like all of them supine, only an AP with a scout before. So complete preference to the radiologist or the PA who's running the exam. But it does need to be the correct amount. For this, it does say if the drug remains, do not put it back into the original container. Dispose of it according to institutional policy. So they just don't want you drawing up and then putting it back in if you're not using it all. Because then you're cross-contaminating. Depending on what you're touching the needle or the hub with, if you're injecting it or putting it into another container, it's sterile in the vial. If you're doing anything intravenously, intramuscularly. So really anything besides barium is gonna be sterile within the container. You guys know barium is not sterile. We don't use sterile water to mix it. We can use tap water, not a big deal. All right, the right patient. Obviously, you want to verify your patient information before any exam, even before you give drugs again, additionally. So you're gonna say, I know I've already verified your information, but I'm just gonna check again. Can you tell me your name and date of birth? And check their armband one more time before you administer. If anything's incorrect on the armband, remember we stop, get it fixed before we go forward, right? You should see that practice, right? Everybody see that? Nobody's doing exams with bad armbands, right? All right, good, important thing to know. So stop if something doesn't match, get the correction made and pick up where you left off. The drug must be administered at the right time, depending on the exam. One that pops into my head immediately is a small bowel follow-through. So we administer the contrast when the patient comes in, they're in PO, they drink it. A radiologist may want us to take a 30-minute film. We take a 30-minute film and they say, okay, I need you to give her more contrast, so give her another bottle of barium in 10 minutes. So you're gonna be writing down every time you're administering anything to anyone, right? So documentation, if you didn't document it, it didn't happen. Okay, protect yourself. Make sure you're protecting yourself when you're charting. Also, after you give the patient the drug, you never want to leave them. Why?
Reaction.
Reactions. Okay, so mild, moderate, or severes. Barium, which is what we typically use, has a very low toxicity, high atomic number, low reactivity. So it does not react. I've only had like one person ever have a reaction to barium. Not even sure that it was the barium. Could have been something else. We use Crystal Light. They don't use Crystal Light anymore usually because it has red dye in it and people can be allergic to it. So I'm not even sure if the patient was actually allergic to it, but typically your reactions are gonna stem for water-soluble iodinated contrast, right? Anybody ever had a patient react? No? No? Oh, you guys are lucky. You will, one day, at some point. But you do need to be familiar with the signs of the mild, moderate to severe to know what to do next. So if your patient's having a mild reaction, like maybe they are having a metallic taste in their mouth or they're getting hives, you wanna let somebody know. Obviously, if they're going into an anaphylactic shock, you wanna stop the exam, call a code. So depending on the severity, the instructions might change. The right route, we're gonna talk about that. It is specific to the exam though, what type of drug you're using, but we're gonna talk about all the different routes in just a minute. And then at the end of all of this, you want to make sure you document. So you're gonna document the drug you used, the amount, the route of administration, the date and the time, if the patient refused to take the medication, and all other pertinent information that would be useful for review. I've had many friends that have saved their jobs by documenting. So if a patient complains about something, or they have a different story than you, or they say they had a reaction, or anything really. Actually, I had a friend who worked in Mammo who was challenged by her patient who wanted to report her for sexual harassment. And because my friend documented well in the chart, it was able to save her job. She had like 2 interactions with the patient, and she noted both times that the patient was irate, that she was demonstrating symptoms of schizophrenia, and that she was kind of raging in the room. So if you document these things, you can protect your employment and you as a person. You obviously don't want to be sued. You're protected under the facility that you work at, but you don't want any discrepancies to where you would have to meet with risk management or a panel of people to be analyzed. It's not a fun process. So protect yourself by documenting everything that seems pertinent. All right, so let's flip the page. Let's talk about the different routes. So first they talk about the intral. So intral routes include oral, sublingual, buccal, or rectal. So oral, obviously in the mouth, right? Sublingual is where?
Under tongue.
Under the tongue. Buccal,
Nasal.
in the cheek.
What?
Buccal, in the cheek.
Oh.
Sorry, where's this information?
That's not.
I'm on
here.
page
It's
287.
not in here.
Oh, it's not in the older book?
It says oral, sublingual,
So you have the new
topical,
one?
and parental.
So we got like 3 different, that one is new, so you just have a different version than everybody else. Sorry, guys. Do you you should still have the routes in there. They're not gonna take out the routes in the new
Right
book.
here. Oral,
But it
sublingual,
doesn't have rectal and whatever.
buccal. Topical. Well, we learned all this, but we just have this spot.
Alright, so we have intral routes, oral, sublingual, buccal, or rectal. Everybody with us?
What was the
Buccal. B-U-C-C-A-L. Is that one left out on the other one?
Yeah.
Okay, so route by cheek. So cheek is your buccal. So route by cheek, so inside the cheek. They do that a lot when you have patients like babies or children that don't want to take drugs. Instead of putting it under their tongue, they can spit it out. You just rub it on their cheek and it absorbs. So think about like
I didn't know
Zofran if a baby's vomiting. All right, then we're gonna turn the page to topical routes. They talk about topical routes involving the application of the drug directly onto the skin, and it gives you a term, transdermal. Remember, trans, across or over. So across or over the skin. Transdermal patches are really helpful if you have anything topically that needs to be given to you, because it's time released and it's dose calculated. So think of it like a tube of Neosporin. If you want to medicate your wound with Neosporin, you squeeze it out. You have no idea really how much you're using, and it's not time released, you're using it all right then. If you have a transdermal patch, it's released over time into your skin, and it's a specific dose within the patch, so you can track it a little better. All right, then we have our other main route, which is parenteral or parenteral. This means that the drug is administered by a route other than the GI tract, typically injected using a syringe or a needle. So those intral routes, the oral, the buccal, the sublingual, and the rectal, those are intral, a separate category. Then we have parenteral, which is anything other than the GI tract, so nothing in the mouth, usually administered with a syringe and a needle, okay? So there's 4 different routes within this one. There's ID, intradermal, IM, intramuscular, and then we have subcutaneous or IV. Saying that everybody's still tracking? Intradermal. Intradermal, so INTRA dermal, intradermal, so into the dermis.
IV, intradermal, intravenous, and what was the last one?
Intramuscular,
Intramuscular.
subcutaneous, intravenous, and intradermal. So OSHA is gonna regulate standards for bloodborne pathogens and mandating the use of universal precautions, what are universal precautions?
Just protecting yourself.
Okay, what's standard precaution? Standard precaution.
It's
Okay.
what you do with every patient, just masks and.
What you do with every patient, so standard precaution. So I'm gonna treat everyone like they have HIV, COVID, MRSA, everything. They have it all, right? Universal precaution. So universal precaution, standard precaution, those are regulated by OSHA to keep us safe. That means that we're gonna use gloves with every patient, right? Now we use masks all the time, so that there was a time when that was not standard PPE, but now it is. And they also have a needle stick safety prevention program. And this just helps keep us safe. Needle sticks are really big in the field of radiology as far as employers and employees getting stuck. Really easy ways to prevent yourself from getting stuck: never recapping needles and putting your needles where they're supposed to be. Meaning you never take your hand off the needle and put it on the tray. Has anybody ever seen a sponge on a sterile tray where they stick needles? It almost looks like a round little sponge on a sterile tray. All it's used for, it's hard in the center, all it is used for is for holding needles. So if you're doing some kind of biopsy, if you end up going to another modality, or you're doing a myelogram or an arthrogram and you're helping setting up a tray, you'll get everything ready. The needles obviously weren't used. So if you get stuck by a needle that's not used, not a big deal. Obviously you don't want to get stuck. So pay attention to what you're doing. But after the patient has been injected, that's when it's a super big deal. So once you take the needle out of a patient, you either want to stick it into the sponge or go into the sharps container with it. So once your hand is off of it, it's safe, right? So I'm taking it out of my patient, directly from my patient, either in the sponge that's gonna hold it or in the sharps container. The sponge, the needle goes down, so it's never exposed and you're not able to penetrate it. So it shouldn't be sticking you. There's been a lot of talk about changing biopsy trays in the field of ultrasound MR and mammography because people are getting stuck. If you ever do get stuck by a needle that's wounding a patient, you're gonna have to do some prophylactic treatment, and they will treat you like the patient has everything. So if this patient just moved here and they brought in films from a different facility, we have really no information on them, no blood work, they're gonna treat you for HIV, Hep B, and any other thing that could be passed through the blood prophylactically. Once the patient's blood is drawn and they figure out what's actually pertinent and what you actually need to take, then you can back off the meds. But you don't want to have to get into a situation like this because those meds are not fun to take. They can give you all kinds of reactions. I had a friend who had like really bad night terrors and insomnia. Somebody I know had a seizure from one of the medications. So obviously you don't want to take medication that you don't have to take, but they're going to give it to you in employee health to protect you just in case the patient did have that before they have all of the information. So all that to say, be careful when you're using needles, right? It does give you the parts of the needle. I'm on page 289. So it tells you the hub, that is the part that attaches to the syringe, the cannula, also known as the shaft, which is the length of the metal part, and then 3 is the bevel, which is the slanted part of the needle tip. So as you go up in gauge, you go down in size. So a 25 gauge needle is smaller than a 19 gauge needle. Everybody tracking? So the larger you go up in gauge, the smaller you go in diameter. Inverse related. It does give you some common gauges that are used, 19, 20, 21, 23, 25. And it also tells you that the bevel should always be up. So the bevel of the needle, where it slants, if this is my bevel, here's my needle right here. So my needle is angled here. This bevel is always going to be up. I'm never going to turn it to where it's entering in the vein down because it can plug to the vein wall and you won't get any blood out. Also, it pierces through tissue and muscle very easy if the bevel is up. It should be sharp, and obviously if you poke the person quickly, it shouldn't hurt them very much because you're not engaging with much nerve contact. The rest of this information in this chapter, before we talk about the actual injections, is information for venipuncture. I'm gonna wait to go over it. If we do get access to the lab, we'll go over it while I'm walking you through the procedure. If we don't get access to it, I'll walk you through it later, just discussing it. But look over the sheet if you want to, or you can wait. So I'm gonna skip to page 292, where it talks about the different parenteral administration methods. So first we're gonna talk about intradermal.
I have a question.
Yeah.
Did you say the bevel up or down?
Bevel up.
Bevel.
Yep, always bevel up. All right, so first it talks about the intradermal injection. You might not have this in everybody, you don't have this one?
It starts to talk about like subcutaneous and
Okay.
intramuscular, yeah.
We still have the dermal.
Okay.
Dermal.
So intradermal, if this one is not in your textbook, you can just listen for just a second. Not super important information. But they're administered by injections, injecting the contents of the syringe between the layers of the skin. Intradermal injection sites are inside of the lower arm as for testing if you're exposed to TB. So the PPD test that they do is an intradermal. When they do a very, very shallow injection here, just to puff it up, just an intradermal. Then you have an intramuscular injection. This is when the drug is placed directly into the muscle tissue that lies under the subcutaneous, so it's deeper. Have to go a little bit deeper in the skin. You don't need to know any of the gauge sizes or needle lengths for each of these, so I would not even read that at all. It's not pertinent to us. Subcutaneous injections, this is when a drug is administered under the skin into the subcutaneous that is under the epidermis layers. So deeper than this intradermals, but more shallow than the intramuscular. So it's kind of the in-between there. They talk about subcutaneous absorption being slower than the intramuscular route because of the lack of vascularity. So intramuscular obviously is the closest one that you can get before you actually hit a vein, so it's the deepest point. If it doesn't need to be actually administered to the cardiovascular system or the venous system, they'll give it to you intramuscularly. It usually hurts less because it's a deeper part of your body. You have more muscle tissue. Your muscles are moving constantly, so it will work out the cramps. Make sense? Everybody tracking still? And then the last one here is an intravenous, which I'll just talk to you about this one just a little bit. 294, remember we're gonna skip over most of it just in case we get lab access. And I'll let you guys know, we'll probably have to schedule it, so I wouldn't say it's gonna be next week. But I'll try to get it this month. That way we can get in there and do some venipuncture. So intravenous, the drug is placed directly into the vein and rapid action occurs in minutes. Why? Because our heart's pumping, so our blood is rushing, right? So it's introduced to our body the fastest intravenously. It does give you the sites, which we're gonna talk about that when we cover venipuncture. On page 296, it shows you your basilic vein and your cephalic vein. So your basilic, I always try to remember it, it's closer to your body. So if you're in an anatomical position like this, it's the one running closer to your body. Basilic, cephalic, and then antecubital region is right here. This is where we're gonna typically do venipuncture. So basilic closer to your body, over here. Cephalic over here, more lateral, and then antecubital region is your elbow region. Obviously, if you are performing venipuncture and any leaking or extravasation occurs, you want to stop. I'm sure somebody at some point has given you a bad IV or pricked you the wrong way. Everybody has their own experience, right? Maybe they took the needle out halfway or they went back in. I remember when I was in program, I had to do a venipuncture class. So I had to do a lab class before I was actually admitted to the program. And we drew on each other every week, and my friend was drawing on me, and she had a butterfly needle in with a Vacutainer, and when she went to switch the tube out, her hand slipped and the hub of the needle went all the way in my arm. So uncomfortable, right? I almost passed out. Right, that story. Right, she didn't need to, but that's what happens sometimes when you're not paying attention. But you all have your own bad experiences, if you will, when you're doing this, so try to be cautious and take care of your patients as best you can. If you do end up working in a field like MR, CT, nuke med, PET, or SPECT, you're probably gonna do IVs all the time, so you're gonna get really good at these. Sometimes if you have a patient that's just really, really hard to stick and you don't wanna hurt them, or you've already stuck them once, maybe twice, you can always call the PIC team. They have them located at every facility. These are nurses that use sonograms to find the veins, so it's impossible to miss because you can see straight through the sonogram, right? So they'll show a light and they can get an actual sonogram out with a transducer to feel the vein and see the needle go in. So that's an option too, if you're really having a hard time getting a stick on somebody for something. It also talks about, in the venipuncture section, under this little subcategory, it says intravenous injection methods, that there's 3 methods in which you can introduce the drugs. The first one is a single administration in which the drug is injected slowly. So single administration, the drug is administered slowly. So they've started an IV on you, they want to give you Benadryl directly, so they take the the catheter connected to the hub adapter off, unscrew the lock lure on the actual syringe, and they push a drug slowly directly into your venous line. The other way you could do it is introducing a drug by an intravenous bolus or a push. This is going to be a fast injection, so nothing thick, obviously. Anything that's a thicker substance, you have to push really slow, so you don't have any snaps in the needles or blows of your veins, because it's a thicker substance that needs to be mixed. So a push or a bolus. This is going to be really, really fast. Think about people coding, how we need to push drugs really quickly, things like that. And then the third method is a drip infusion. So if somebody has a bag beside them, the nurse or the physician inserts drugs directly into the bag, so it mixes with the solution and it drips very slowly. So like 10 to 20 drips per minute is an acceptable flow rate, it says. 10 to 20 drips per minute, an acceptable flow rate. So a very, very slow injection. And really that's it. Do you guys want to talk about anything else for those patient care vital signs? We're gonna do venipuncture, so don't worry about that. We're either gonna do it in the lab or we'll talk about it and I'll walk you through it. Probably not gonna be able to get a bunch of
read this
marks
whole
though,
book.
because they just don't have them. The fake marks.
Jesus Christ.
We have a bunch of marks in this room, if they're able to be used, right? All right, so hopefully that will help you out a little bit and catch you up to pace with your vital signs and you're feeling more comfortable. Did everybody get a chance to use the pulse ox? Yeah? Okay, cool. Cool. All right, so next week, next class, we're gonna do the next chapter in Rad Bio. So it should be chapter 2? Chapter 2 in Rad Bio. We're also going to go over chapter 2 in pathology. Do not pre-read this chapter because there's a lot of junk in it for radiologists, right? So you're not ever going to be able to identify all of the pathology in this chapter. It's very long. So I'm going to guide you through this in class. If you want to pre-read, go through Rad Bio chapter 2 for this week.
You mean chapter 3 for pathology or chapter 2?
Chapter 2, I think. Is it chapter 2?
Chapter 3 goes over the pathology of
Oh,
each.
chapter 3 for pathology. Don't pre-read it. Chest.
Yeah.
Chest.
We did want it.
Also next
did
week, we're gonna get into
Yeah,
the
okay.
lab before we leave. So we're gonna get into skull positioning. So